Bilateral transpetrosal approaches are effective corridors to petroclival lesions and basic artery aneurysms. They can be divided in anterior petrosectomy and posterior petrosectomy. A detailed knowledge of the anatomy of the temporal bone is essential in order to be able to perform these approaches. It is very important to understand the relationship within the structures of the temporal bone from a superior perspective, from an inferior perspective, and from an intracranial perspective. It is also very important to understand the anatomy of each single component of the temporal bone. The anterior transpetrosal approach consists of a subtemporal craniotomy and an anterior petrosectomy, and it provides better exposure for aneurysms on the mid and upper portion of the basic artery and for petroclival tumors. The main advantage is that it allows for hearing preservation. The patient is positioned in a 90-degree lateral as in a standard subtemporal approach. The skin incision could be a semicircular incision based on the external acoustic canal, or a straight incision or a lazy S incision anterior and superior to the tragus. The skin flap is elevated and reflected inferiorly. In a cadaver setting, it is always advisable to do more than one burr hole, because the dura is particularly attached to the inner side of the bone. A standard craniotomy is performed. Care is taken not to injure the underlying dura. The bone flap is elevated. The dura is detached from the middle fossa floor. Using a large 4 or 5 mm cutting burr, the bone is drilled away until it is flush with the floor of middle fossa. Any bony spur is drilled away until there is no obstruction to the middle fossa floor. The first target is to identify middle meningeal artery and foramen spinosum, and V3 and foramen ovale. Middle meningeal artery is identified and cut, and interdural dissection is continued between the periosteum and the dura propria of the temporal lobe. The dissection continues anteriorly and posteriorly, leaving the periosteum on the floor of middle fossa. This will guarantee that the GSPN is mixed with the periosteum and is left on the middle fossa floor without any possibility of injury to the nerve. The GSPN is isolated, the foramen spinosum is identified. GSPN is in correspondence of the intrapetrous carotid artery. The GSPN needs to be cut and reflected anteriorly in order to be able to expose the intrapetrous carotid artery. The Meckel cave is identified, and using a diamond burr, the intrapetrous carotid artery is completely exposed. It's very important to understand the relationship between the intrapetrous carotid artery and the cochlea. Bone is drilled medially and laterally to the ICA. It's very important to understand where the cochlea is located. And you can see the correspondence between GSP and intrapetrous carotid artery and the location of the cochlea. There are several techniques in order to identify the course of the internal acoustic canal. One of the most effective techniques is to identify the arcueminence and the GSPN. The arcueminence will correspond deeply to the superior semicircular canal. GSPN will correspond to the intrapetrous carotid artery, The bisecting of the angle between these two structures corresponds to the course of the internal acoustic canal. The cochlea is in the vertex of the angle between the IAC and GSPN. The facial nerve runs from medial to lateral, from inferior to superior, and because of that, the roof of the canal is thicker medially in correspondence of the petrous ridge. It's much safer to start drilling medially, where the roof of the canal is much thicker, and the drilling starts with a large 4 mm cutting burr. It's very important to notice how the bone at this level is very friable, cancellous, and the dissection starts at the level or the intersection between V3 and petrous ridge. As the dissection proceeds posteriorly, the consistency of the bone changes from cancellous to compact as any other skull-based structure. As the dissection approaches a neurovascular structure, the consistency of the bone changes. And finally, when the dura is approached, the drill can be changed to a diamond burr, and the internal acoustic canal is skeletonized circumferentially from posterior to anterior, uncovering the dura on the internal acoustic canal. Once the internal acoustic canal is skeletonized, the drilling proceeds inferiorly and medially, exposing the dura of the posterior fossa. A little shallow of bone is left in place at the level of the petrous ridge in order to be able to sustain the spatulas. Posterior fossa dura is completely uncovered, and the dissection proceeds medially towards the clivus until the inferior petrosal sinus is exposed. The dura of the canal is completely uncovered. The dura of the posterior fossa is uncovered. The canal is skeletonized circumferentially. The most important structures are visible. The cochlea is located in the vertex of the angle between the IAC and the GSPN. Finally, spatula released. The dura is completely freed all the way down to the clivus. The inferior petrosal sinus is visible. The drilling continues until the clivus. And the final result is that the dura is completely uncovered all the way down to the inferior petrosal sinus. The postmeatal and premeatal triangles are completely free from the bone. The cochlea is in the vertex of the angle between IAC and the intrapedial sclerotic artery. And finally, the dura can be opened. The dura cut is a T shape. The first dura cut is parallel to the superior petrosal sinus, as in a standard subtemporal approach, towards V3. The second cut is perpendicular to the first. Care should be taken to the trigeminal nerve, which is crossing the petrous apex. Tentorium is cut, and the second side of the dura cut, it goes to the internal acoustic canal until the fundus, and the dura of the posterior fossa is finally open, revealing the content of the internal acoustic canal. Is visible the ICA, the cement nerve, and the superior vestibular nerve. The ICA is looping between these two structures. And finally, after opening the arachnoid, the basic artery is visible, together with the branching off of the ICA, and the ICA is crossing the abducer nerve, which is running toward the Dorello canal and finally the cavernous sinus. All the structures are finally visible. You can see the artery eminence, internal acoustic canal, the cochlea, the ICA, the basic artery, trigeminal nerve, and also the vertebral basilar junction with the internal acoustic canal content.